series of studies and publications validate the need for interprofessional education, or IPE. In 1991, the Pew Health Professions Commission stated that health professions education must prepare individuals to work effectively in health professions teams. The Josiah Macy Foundation provided recommendations for more effective educational programs, which included 8 recommendations related to IPE. The Institute of Healthcare Improvement, with its focus on improving the quality and safety of healthcare, includes teamwork as a necessary component. The Institute of Medicine has released a series of reports related to patient safety and quality. In the report, Health Professions Education, A Bridge to Quality, the IOM called for a dramatic restructuring of health professions educations to include practitioners who provide patient-centered care, train in interprofessional teams, use research evidence for making clinical decisions, learn how to think about complex systems, and use principles of quality improvement to improve patient safety, and to use informatics to guide data collection and care decisions. International organizations support the importance of IPE and provide resources such as teaching materials, conceptual models, thoughtful discussion, as well as objectives and evaluation. Health professions organizations, who are responsible for establishing curricular benchmarks and accreditation standards, have included one or more competencies related to interprofessional education in their criteria for training programs. Mitchell and colleagues succinctly summarize 8 components of successful IPE initiatives as displayed on this slide. Each will be discussed separately. Even with the endorsement and expectation from professional organizations who oversee curricular standards for health professions education, change is difficult. For interprofessional students to learn interactively for the purpose of improving health care requires changes in how students are educated. This educational change is far more than putting students side by side in a classroom or adding additional content on teamwork and collaboration. It requires the support of top leaders, such as those listed on this slide. Embedding the goal of IPE into the institution's strategic plan grounds the importance of this educational initiative into the heart of an organization and underscores the need to measure both process and outcomes. For example, at UNMC, 2 goals were embedded in the strategic plan. 1, establish sustainable interprofessional education, and 2, become a leader in educating for healthcare quality and safety. Although institutional leadership is essential for IPE, the support of at least a few faculty is essential. A core group of faculty who understand the importance of IPE and are willing to move it forward will greatly enhance this mission. Faculty development is important and key to bringing others along. Faculty development promotes an understanding of the conceptual and practical underpinnings of IPE, the skills necessary to teach in an interprofessional manner, and the latest information on quality and safety. Although IPE goes well beyond the quality and safety of patient care, tying it to this important issue is a way to galvanize faculty and lessen the barriers to doing one more thing. Many faculty will quickly champion the need to improve patient care, and patient care can serve as a catalyst to bring groups together. Capitalizing on the support of the institutional leadership, ways to include IPE in faculty workload should be explored and hopefully placed into faculty workload expectations. Until this is accomplished, however, faculty should expect to volunteer their time beyond their existing workload. When given the chance to learn in an interprofessional group, students quickly grasp the importance of this educational initiative. Student support and enthusiasm in the planning and development of interprofessional initiatives can be used to speed change and gain greater faculty buy-in. Institutional policies provide the formal framework and legitimize IPE efforts. Combined with institutional leadership and faculty champions, policies support new initiatives. At one academic medical center, for example, the associate deans created an interprofessional curriculum committee. The committee is comprised of a curriculum committee member from each college and a faculty champion from each college. Student representatives sit on the committee as well. This committee provides an important link between each college's faculty and curriculum committees and provides a communication pathway to the academic deans of each college. The establishment of this committee symbolizes the importance of IPE and provides an interprofessional working group who is responsible for developing and evaluating IPE across disciplines. Finding time for IPE activities is frequently cited as the major barrier to implementation. In an effort to begin small but establish the importance of IPE, the deans of each college agreed to setting aside 2 hours per month for interprofessional learning. Other activities can occur outside of this time frame, but the 2 hours enhances the probability that all students will be involved in IPE activities. Finally, a campus-wide academic evaluation and assessment committee established competencies for every graduate of the academic medical center to obtain. The Interprofessional Evaluation and Assessment Committee adapted the Common Program Requirements, General Competencies, from the Accrediting Council of Graduate Medical Education. Many of the competencies support IPE, for example. Learners are expected to work in interprofessional teams to enhance patient safety and improve patient care quality, and communicate effectively with all members of the healthcare team. Physical infrastructure can enhance the ease with which IPE can occur. Colleges that are in close proximity will experience less physical barriers when creating opportunities for students to interact. Rooms that can accommodate large numbers of students and breakout rooms for experiential learning are useful. Learning labs and simulation facilities provide simulated clinical environments for students to practice clinical skills combined with professional behaviors such as communication and teamwork. Student-run clinics provide fertile ground for students of multiple disciplines to learn about each other's profession, to recognize what each brings to patient care, and to patient care and outcomes. Distance technology can be used to bring students together as well. Collaborative relationships are needed across disciplines for the successful integration of interprofessional learning activities. As previously mentioned, a beginning focus on patient safety and quality outcomes creates common goals and fosters collaboration. Collaborative relationships are needed at all levels of the organization, from the leadership to faculty, staff, and students. Probably the greatest flexibility is needed in scheduling learning activities. It is not uncommon, even within the same academic setting, for health professions' academic calendars to be different. Faculty who are used to being in control of their classroom and skills lab will need to work in teams to accomplish IPE. When 2 or more health professions get together, compromise on learning goals, activities, and evaluation outcomes is essential. Each profession will bring their own personal values regarding what is essential content. Thus, role modeling flexibility will quicken the process with which IPE activities are developed and implemented. At our Academic Health Center, UNMC, we are using a plan, do, study, act philosophy when implementing small, experiential learning activities. This allows faculty to try multiple activities and work in an area they are most comfortable or familiar with, and it increases the speed of change. Examples include interprofessional simulations and skills activities, ethics rounds and discussions, problem-based learning cases, service learning activities, clinically based quality improvement exercises, and student-run clinics. Over time, evaluation of learning will assist in leveling learning activities. It can be challenging given the different levels at which pharmacy, nursing, and medical students, for example, are exposed to clinical care. For example, first-year medical students do not experience hospital-based care, but first-year nursing students do. Thus, determining when to expose students to a clinically based simulation requires creativity and flexibility regarding planning and evaluation. Finally, we have found that flexibility is needed in grading as well. Different academic programs require activities to be part of service learning, part of a formal course grade, or part of a clinical pass-fail experience. Barnsteiner and colleagues suggest that an organization has fully engaged in IPE when the following criteria have been met. There is a philosophy of IPE that permeates the organization. Interprofessional faculty co-create the learning experiences and expected outcomes. Students have integrated and experiential learning related to quality and safety. IPE is required for all students. Established competencies are demonstrated by all students, and there is an established infrastructure to support IPE.